Hello everyone. Again, I welcome you all to my lecture class, and in my today's lecture class, I am going to talk about the management of autonomic dysfunction. In my previous classes, I have already talked about the anatomy and physiology of autonomic nervous system, and I have also talked about various autonomic function tests by which we can diagnose a case of autonomic dysfunction. So in today's class, I'm going to talk about the management of a very common autonomic dysfunction which we usually come across in our clinical practice. Now, what can be the symptoms of autonomic dysfunction? The patient may present with orthostatic intolerance. That means on standing, the patient will develop nausea, lightheadedness, giddiness, or pre-syncope. The patient may present with sweating problem. It may be increased sweating, that is hyperhidrosis, or reduced sweating, that is hypohidrosis. The patient may present with bladder problems like urinary incontinence, increased urinary frequency, hesitancy. Patient may present with gastroparesis and bowel disturbance like constipation. The patient may also present with sexual disturbance like impotency. Now, what are the common causes of autonomic dysfunction? The causes of autonomic dysfunction can be at the level of brain, can be at the level of spinal cord, or maybe at the level of peripheral nerves, or at the level of neuromuscular junction. So, certain common disorders of brain like multisystem atrophy or Parkinson's disease, Lewy body dementia, and various other causes can result in autonomic dysfunction. Disorders of spinal cord like multiple sclerosis or maybe syringomyelia or amyotrophic lateral sclerosis, and various other causes can give rise to autonomic dysfunction. Autonomic peripheral neuropathy can result in autonomic dysfunction, and there are certain specific autonomic syndromes. Just for example, one of them is POTS, that is postural orthostatic tachycardia syndrome, about which we are going to discuss in my next class. So now let's talk about the management of orthostatic hypotension, which is the commonest autonomic dysfunction which we come across during our clinical practice. Now, what is orthostatic hypotension? Orthostatic hypotension means there is reduction in systolic blood pressure by 20 mm of mercury or diastolic blood pressure by more than or equal to 10 mm of mercury after 3 minutes of standing. So, to diagnose a case of orthostatic hypotension, initially we should measure the blood pressure in supine position. Then we should make the patient stand for 3 minutes, and then we should again take the blood pressure and see the drop in blood pressure. Systolic BP will drop by 20 or more, and diastolic BP will drop by 10 or more. Now, orthostatic hypotension can be neurogenic or it can be non-neurogenic. So how do we differentiate clinically between neurogenic and non-neurogenic orthostatic hypotension is that we should look at the heart rate. In cases of non-neurogenic orthostatic hypotension, the heart rate should increase by more than or equal to 15 beats per minute on standing. Non-neurogenic causes of orthostatic hypotension can be anemia, or it can be hypovolemia. And neurogenic causes we have already discussed. There are many causes at the level of brain, spinal cord, or peripheral nerves, or myoneural junction. Now, coming to the treatment of orthostatic hypotension. First of all, we should try to treat the underlying cause of orthostatic hypotension, and we should try to avoid the precipitating factors which may increase orthostatic hypotension. So, management of orthostatic hypotension can be non-pharmacological management or pharmacological management. In the non-pharmacological management, first of all, patient's education is very important. Patient should be taught about the various stressors of orthostatic hypotension. Orthostatic hypotension stressors can be exposure to heat or a warm bath, or maybe exercise, or maybe a heavy meal. Okay, after a heavy exercise or having a heavy meal or warm bath, the patient may develop orthostatic hypotension. So patient should try to recognize the stressor of their orthostatic hypotension and should be cautious and cautious about it. Okay, and we should advise for high fluid intake. Okay, so that the urine output is maintained up to 1.5 to 2 to 2.5 liter per day. Okay, high salt intake. Okay, we can advise up to 10 to 20 grams of salt per day. Then physical counter maneuvers should be taught to the patient. Just for example, crossing the leg, okay, or dangling the leg on the edge of the bed while standing up from lying down position in the morning time. Okay, we should talk about the postural adjustment. Okay, whenever there is any transition between the posture, it should be gradual, not like sudden. The patient should not stand suddenly from a sleeping posture, or patient should not stand suddenly from a sitting posture. We should also advise for compressive garments. Okay, compressive garments will increase the peripheral resistance and will prevent orthostatic hypotension. Then anemia, if there is anemia or hypovolemia, it should be corrected. So this is about non-pharmacological management of orthostatic hypotension. Coming to the pharmacological management of orthostatic hypotension, there are a few drugs which can be used for the symptomatic relief of orthostatic hypotension. One of them is midodrine, which is a very important drug. It is an alpha 1 agonist. Dosing of midodrine can be 5 to 10 milligram 3 times a day. But it has been seen that if we dose it in a decreasing order, like just for example 15 milligram in the morning, then 10 milligram in the noon, and 5 milligram in the afternoon, if we dose in this way in a decreasing order, then the patient usually responds well. So we should remember that. Droxidopa can also be used for certain specific neurological diseases like Parkinson's disease or multisystem atrophy. Pyridostigmine can also be used, which enhances the ganglionic transmission, and it is probably the only drug which does not cause supine hypertension. Okay, with other drugs like midodrine or droxidopa or maybe fludrocortisone, the common side effect is supine hypertension, which is not caused by pyridostigmine because it enhances the ganglionic transmission, probably only in standing position, not in supine position. So in this way, supine hypertension can be avoided. Fludrocortisone is also one of the very important drugs which can be used to ameliorate the symptoms of orthostatic hypotension. The dosing can be 0.1 to 0.3 milligram per day. Okay. There is one more combination drug, that is atomoxetine and euhimbim, which is not FDA approved, but this can be used for the treatment of orthostatic hypotension. Okay, atomoxetine is a inhibitor of norepinephrine reuptake transporter. Okay, it inhibits norepinephrine reuptake transporter. Okay, and euhimbin is a alpha 2 antagonist. Okay, so when these two drugs are combined, okay, they ameliorate the symptoms of orthostatic hypotension. And as if I have already mentioned, okay, the underlying cause should always be treated. Okay, treatment of underlying cause may ameliorate the orthostatic hypotension, and also the precipitating factors for orthostatic hypotension should be avoided. One of the very common precipitating factor is various drugs. For example, antihypertensive drugs, antidepressant, levodopa, opioids, barbiturates, insulins. These are the few common drugs, and there are many other drugs also which can cause or which can precipitate orthostatic hypotension. So we should be very cautious giving these drugs in a patient of autonomic dysfunction, and as far as possible we should avoid. So this is all about the management of autonomic dysfunction in short. Thank you.